Hey, I'm David Cantor, and I've actually been with ICF Macro and working on part of the mChip project for the last couple of years. And I'm really quite amazed at, what data collection and data analysis was like when I started in this 25 years ago, which also was under USAID contracts, where we were taking mainframe Fortran routines and downloading them to PCs and running them on PCs and coming up with some data for analysis. And we've come, in just that really short time, full circle. So in a way, I'm sort of a dinosaur, and also in terms of how we, what we're using the mobiles for. We're collecting data. We're not doing anything like text messaging or anything too cool, but we're using them as a device for high quality data collection for fast information, and the uploading feature to a server so that they're available quickly for people to look at results. So in that case, I'd like to think of myself as an M dinosaur. So from that, I'll kind of talk a little bit about what we did with this quality of care survey that we've launched in 6 countries under the mChip project. And basically what we're doing, the goal here was to evaluate quality of health services in health clinics, in hospitals, regional hospitals, dispensaries, and to evaluate a set of 6 tools. The one I'm going to actually focus on, though, is the observational assessments that took place in the labor and delivery room. And we've done this now under mChip in 5 countries. And this has all been during this past year using mobile phones. We've done this in Kenya, Tanzania, Rwanda, Madagascar, and Ethiopia, all since March. We have results now from 3 of these countries. And I don't think we could actually have done the kind of assessment of the quality of care using paper and pencil, using the traditional means. And I'll explain a little bit why. Again, there are sort of 3 actors involved with this. You've got observers that we've trained to observe health workers in a clinical setting, taking care of patients. And in the case of this particular labor and delivery tool, we have women who are in various stages of labor who have come into the facility. And so what the observer has to do is observe the health worker and make sure they are carrying out all the appropriate steps as to what they're supposed to do. Are they washing their hands? Are they wearing gloves? Are they taking the blood pressure? And so what we've developed on the mobile phone, and this is kind of a real on-the-ground description, is we've developed checklists for the observers to, as they're observing, to find and check off, yes, they did this, no, they didn't do this. Now, they're not going to say no, because it might happen. It's very different than doing a survey. So the mobile phone gives you the opportunity to load several cases, or several women in this case, who are in various stages of labor at the same time, and you can go back and forth. In other words, I might have a observer who has 2 women in labor, various stages of pregnancy, and the observations are taking place over an extended period of time. Well, they may need to hop back and forth. The mobile phone allows you to do that. Pull up one case and save it, go to the other. Paper and pencil, you're going to be rifling through all of this. So for an observational assessment, it's really very, I almost can't see how you could do this without a mobile phone. And so what we're starting to see is we're getting the initial amount of data back. We're coming up with different kinds of composite analyses based on these checklist items in terms of essential newborn care and various other indicators. The training experience has also been very positive, I'd say. We've contracted in most places with one of the mChip host, actually not contracted, but one of the mChip host countries is where we've done the training, or with a contractor, an outside contractor. And the people we've trained have been, for the most part, OBGYNs and nurse midwives. And, you know, the technology part has been the least of our problems, I would say. You know, coming up with now it's a very complicated tool, because you have to always allow for complications to happen at any time. If, you know, if a woman starts to go into hemorrhage or preeclampsia, eclampsia, you have to allow for the program to branch into these other sections so you can capture the complications. The program does all these things. Designing the tool in a way that it's meaningful and that you know, the skips and everything is what turns out to be rather complicated. So what's happened is, as we've done these particular observational assessments, we keep tweaking the tool and hopefully making it better. And the technology has always worked. They enter the case and then they're able to transmit it back to a server that we've set up right in country. In the Japigo office in Dar es Salaam, we were able to establish a server right on someone's laptop, and the same thing in Rwanda. In other cases, like in Madagascar, where the cell phone coverage was not so great, we had to wait for the enumerators, the data collectors, to come back to capital in Tana to upload the data. So, you know, the technology part, I feel, is there, and it's almost like the tool design and the content part, you know, can catch up to it at this point, because it was an interesting change doing this as opposed to a survey where you follow, you know, a straight or you know, path, one question after the other. Here, it's very random, because you don't know when the you know, the health worker is going to do what they do, not in any necessarily order.
And what kind of phones did you use?
We used Windows mobile phones, which I know is not a real popular item around here, and you know, it's, you know, for good reason. You know, I can see how the Windows mobile platform is. Everybody says it's going to go away, but I'll tell you, one of the things about the software that we used. And it's a little program from these Australian developers. I've been using it since 2003 for other projects. It has a great interface. It's excellent for training. The data collectors can see the skips. You can build in logic. You can build in consistency, range checks. And the person that's filling out the form only sees the next, you know, question that they're supposed to see. We also enabled it we actually took a picture of the partograph during the observation. And we also included a field for audio notes, which is attached to the record for each case, so that when it's transmitted back to the central office, there's some anecdotal evidence that might fill in the gaps in terms of some of the, you know, questionable information. So it's a different kind of data collection process. You almost have to put yourself in, you know, the position of, you know, how is the health worker going to carry out these steps, and you want to make sure that they're going to be able to navigate back to the particular checklist item, and, you know, be able to find it as part of the entire assessment.